Greetings, I'm Ritika here. The present video is about Staphylococcus capitis. General characteristics. Staphylococcus capitis is belong to gram-positive bacteria and it is spherical shaped cocci. Staphylococcus capitis is arranged in a grape-like cluster. The size of the Staphylococcus capitis is 0.8 to 1.2 micrometer in diameter and it is a non-motile in nature. Capsule is absent, endospores absent. The respiration of the Staphylococcus capitis is aerobic or facultative anaerobic. Optimum temperature is about 37 degrees Celsius. Optimum pH is 7.0. Habitat of the Staphylococcus capitis is which is found on human scalp and the forehead and which is grown in lipid-rich areas where sebaceous glands are abundant. Staphylococcus capitis was first discovered by Close and Schaeffer in 1975 from human skin. Pathogenicity of Staphylococcus capitis. First, disease transmission. Staphylococcus capitis is transmitted from direct contact with an infected person by using contaminated objects, nosocomial transmission, or transmitted from person to person. Incubation period of Staphylococcus capitis is found to be 3 to 7 days. Virulence factor, biofilm formation, polygamma glutamic acid, and the enzyme endopeptidase ALE1, phenol soluble modulins and exoproteins. Pathogenesis. Staphylococcus capitis initially attached to the host cell surface. Cell surface adhesins like SDRF, SDRG, and SDRH act as a fibrinogen binding molecule which allows attachment to the fibrinogen present on the host cell. Autolysin encoded by the AT1L gene present in the organism is involved in cell separation, stress-induced autolysis, which contributes to the process of biofilm formation. Polygamma glutamic acid, an exopolysaccharide produced by an organism, provides a decreased susceptibility towards the immune cell and phagocytosis. Next, a biofilm formation. Biofilm accumulation generally occurs by the production of poly-N-acetylglucosamine, that is PNAG homopolymer, which facilitates intercellular adhesion between the species. The biofilm acts as a barrier against different immune cells and surrounding microorganisms. Although Staphylococcus capitis is a normal gut flora, may become pathogenesis in immunocompromised patient that is result in endocarditis. Clinical manifestation. Staphylococcus capitis has been linked to peritoneal dialysis, peritonitis, prosthetic valve endocarditis, meningitis, acetabulum osteomyelitis. Neonatal infections. Neonatal infection often associated with the bloodstream infection and sepsis in newborns, especially those in intensive care units. Catheter-related infections. Staphylococcus capitis is known to cause infections related to indwelling medical devices like catheters, leading to localized or systemic infections. Skin and soft tissue infections. Skin and soft tissue infection, which can present as skin abscesses, cellulitis, or surgical site infections. Bacteremia. Staphylococcus capitis can lead to bloodstream infections, which may result in fever, chills, and other systemic symptoms. Endocarditis. In rare cases, it may contribute to infective endocarditis, particularly in patients with predisposing cardiac conditions. Laboratory diagnosis, microscopic examination. By gram staining method, Staphylococcus capitis is found as a violet colored gram positive cocci. In the motility test, Staphylococcus capitis is found to be non-motile. Laboratory diagnosis of culture medium. In nutrient agar, Staphylococcus capitis is found as a circular, cream colored to white color colonies. The colonies are mostly 1 mm in diameter with an entire margin. In mannitol salt agar, Staphylococcus capitis is found as yellow colonies of the size ranges from 1 to 3 are seen, which are surrounded by yellow zones, which indicates the release of acid as a result of mannitol utilization. In blood agar, a wrinkled medium sized, which is found as a 1 to 4 in diameter, beta hemolytic, opaque, rough white colonies are observed. The colony pleomorphism is common on blood agar. Laboratory diagnosis: biochemical test, catalase test positive, oxidase test negative, citrate negative, methyl red test negative, Ogus prosecure negative, and urease test negative, coagulase test negative, DNase test positive, clumping factor negative, gas production positive, H2S production positive, gelatin hydrolysis negative, pigment production that is variable for Staphylococcus capitis, and the lysozyme resistant is found as resistant for Staphylococcus capitis. Treatment of Staphylococcus capitis. Staphylococcus capitis that is sensitive to naphthalene, cephalosporins, and vancomycin with or without rifampin. Cephalotin is the first choice for the treatment of endocarditis caused by Staphylococcus capitis, but in the case of acute necrosis, daptomycin is used. The treatment is comparatively easy as the infections are mostly mild and most members of Staphylococcus capitis are susceptible to most antibiotics. Prevention of Staphylococcus capitis. Coating of biomaterials on the medical devices prevents the attachment of the organism to such devices. Periodic cleaning of wounds and regular dressing should also be employed to avoid infections in those areas. A clean hospital environment is imperative to prevent nosocomial infections. Thank you.